What I want to take you through today is going deeper into the physiologic aspects of advanced illness and actually what happens when you die, so that bringing to light the teachings and how we might make decisions going forward. I also wanted to tell you a little bit about what palliative care is, because people don't know what it is. They often associate it with hospice. It's a specialized type of care. So you have specialties in cardiology, in pulmonology. Now we have another big name, palliative care, which essentially means to ease. It is specialized treatment for people with serious illness. It's focused on providing patients from relief of symptoms, pain, stress of a serious illness, and it is appropriate for any diagnosis. The goal is to improve the quality of life. I happen to hate that term because that is specific to an individual, for both the patient and the family, and it's provided by an interdisciplinary team of doctors, nurses, social workers, volunteers, chaplain, community clergy. We all come together to provide that extra layer of support. Any age, any stage. If anybody uses Cetaphil, that's their logo, and I use it for palliative care. It's appropriate at any age and any stage of illness. So the difference between hospice and palliative care, the way to remember this is all hospice is palliative, not all palliative is hospice. Hospice is a type of palliative care that's reserved for the dying patient. We are the only country in the world that limits that to a prognosis, or to the best of our ability to predict, of 6 months or less. The reason that happened was Medicare statute. They had to set a limit, or they decided they had to set a limit, mostly when hospice was being delivered to both cancer patients and AIDS patients, when we had relatively few treatments for HIV/AIDS, and we had a predictable course of illness that you could pinpoint around 6 months. But now it's for any illness at any age, at the 6 months or less, but that's very hard to predict for the dementia patient, for the heart failure patient, for the patient with chronic lung disease. So it is actually in the process of being reviewed. So you see the two different, this is the old on top, life-prolonging therapies, very sudden switch to hospice care, where you had to forego anything else. A lot of treatments were stopped. Today, it's a very much more fluid process, getting palliative care involved very early, recognizing that at the diagnosis of a serious illness, there are needs of both the patient and the family. Think about the cancer patient. You hear that diagnosis, cancer. What do you think the first thing the person thinks in their head that is getting diagnosed? Will I die from this? The stress of the family members. What is going to happen to my loved one? Some of the myths, because of the old definitions and the old perceptions, are that hospice means giving up. There's a wonderful study that was done a few years ago. It was in the New England Journal and beyond, that looked at terminally ill lung cancer patients. Lung cancer, certain lung cancers are very hard to treat, and it's an ominous diagnosis. People who receive palliative care early and transitioned smoothly into hospice actually lived longer. And that's because the attention to different symptoms, but beyond the symptoms, the spiritual, the existential, the support that's needed, what Father Mindling was talking about, the caregiving needs that are so critical to address early on and have people understand how it's going to progress. The person has to stop all treatments. Not anymore. Individual case by case, looking at what is needed to make sure that we are maximizing symptom relief as much as we can, which is not always complete, to appreciate the stage of life where a lot of suffering is beyond physical suffering. It's existential, it's spiritual, it's emotional. But attending to that person to get to the resources they need to address those issues. Medications used to ease symptoms of the dying will kill the person. I call it morphinophobia, just because it's fun to say. But there is this great fear of these drugs. And I wanted to introduce you to Catherine, who was a 24-year-old young woman. She was working as a waitress, saving money for grad school, when she started to get very dizzy and she passed out a lot. Her roommate found her passed out in their apartment, and they went to the doctor, and after many tests, it was found that she had leukemia. And a lot of things were happening in the bone with leukemia, and she was in severe pain. She was very, very afraid to take pain medications because her brother had a substance abuse history. Her family was also very afraid. The palliative care team was actually called in to help with her pain management because she could not get to her treatments that could cure the disease because she was in such excruciating pain. We started off on very low doses of pain medicines, and we had to gradually increase to pretty high doses of pain medicines. But we achieved relief of the symptom so she could go on to get her treatment. And today, she's cancer-free, and she's married, and she's completed graduate school, and they're looking to adopt a child. So the pain medications, people are afraid of them. You have to make sure you're going to a specialist that knows how to do this well. Unfortunately, both physicians, nurses, and a lot of healthcare professionals haven't had adequate training in this. And that's the reality. Ask for a pain specialist or a palliative care specialist. This patient is dying. Some of these medicines that we use to control different symptoms are often feared. And the fear is that we will hasten death. I'm going to go through the physiologic changes that happen as death approaches, but I want to ask a question. If this patient is in pain or having difficulty breathing, both of which can be relieved adequately with opioids, morphine-like drugs, and we do not give this patient anything, what will happen to this patient? This is a dying patient. Hint. They will die. They will die of their illness. They will likely die faster because of the stress that we are putting on the cardiac system, the respiratory system. He is tied down. You can't really see that very closely. Inability to move, likely for breakdown of skin, and probable pneumonia. He will likely die sooner. In my 20 years of working in palliative care, I have never seen the hastening. I've actually seen the opposite. But again, it is very critical to have somebody who's very well trained at this stage to know what's going on in the body. So the solutions exist, and I would say ask the questions. Gather the information. The directives that Father Mindling brought up have this wonderful, the first directive under this 5th chapter really talks about how we have to provide adequate information to understand what's happening so that people can move forward making decisions that reflect their beliefs and their values. It's where we in the healthcare profession fail miserably. So I hope, although I'm going to give you a very general overview, we can't cover all the illnesses, that we can look at what's happening as a body dies and incorporate Catholic teachings about care of the dying. Here's some initial questions. What is the illness that the individual will die from? Think about the aging population. It's a tsunami right now. They may have multiple chronic illnesses. What is the illness that the person is likely to die from? What is the natural course of that disease? What are we going to expect? What should we expect? And how are the other illnesses, if any, impacting the illness they will die from? I was so glad you had the slide with the causes of death. This is the latest data that's showing the shift in dementia. It's very hard to see. Alzheimer's is at the end. We've seen a 68% increase in the cause of death related to dementia patients, and there are multiple types of dementia, not just Alzheimer's, over the past 10 years. So it's bumping up. I think the latest data actually went from the 3%. I think the latest one, and they're still analyzing it, is now it's 6, and it's expected to go higher. And what other illnesses does the dementia patient possibly have that will impact that? So this is hard to see because of the lighting, I think. But if you can make out the circulatory system that is in the arms and the legs, and everything else that's in the middle, that's the brain, the heart and lungs up top, you have your liver, your stomach, your intestinal system, the bladder. As a person advances in their illness and starts to die, there's an amazing thing that happens. It's a self-preservation. Everything starts to shunt, go closer to the heart, lung, and brain. I call it the Holy Trinity. The heart, lung, and brain, to preserve its life. The unfortunate thing that happens is, as that is happening, the other systems are not being as well taken care of. The circulatory system in particular. So if there's not enough blood flow going to the kidneys and the liver, which are our filters, we're having a buildup in waste products, in medications aren't clearing. So we see a lot of changes that are happening. If one of these three systems, the heart, brain, and lung, is impaired, think of the dementia patient. The brain is impaired. The heart failure patient, the chronic lung patient, and the heart and lung working very closely together. If the kidneys are impaired as well, and we're giving a lot of fluids, the heart is pumping harder, the lungs are trying to catch up, there's nowhere for the fluid to go, and you start to see the respiratory system, the lungs, fill up with fluid because they can't get rid of it. So if any of these are impaired, we're going to see rapidly worsening symptoms. It's really important to recognize these because they're going to impact decisions that are made, whether they be preparing for death, receiving the sacraments, physical and emotional implications for symptom management, but also setting and meeting those goals. Oftentimes we come at the very end, the last few days, and we haven't met those goals because we haven't really talked about it. It may be too late. So earlier on, preparing people for what to expect, completing legal and financial documents, but also considering the caregiving needs that may come up. It's really important to identify this phase because it helps to guide people of what is happening. So you see, again, the general signs and symptoms that we're talking about. The wounds often come from, again, the circulatory system. The nutritional status is decreasing despite adequate nutrition being offered. There is a condition called cachexia. I don't know why we have such difficult terms for some of these things, but we do. Cachexia happens in a lot of illnesses: cancer, heart disease, dementia, HIV, AIDS. And something happens about this stage or earlier when the metabolism of proteins changes. So no matter how much protein or nutrients you give, the cells reject it. And instead of things going into the cells so that they can be used, they leak out and they just gather in the surrounding tissues. You see a lot of swelling. And no matter what we do, whether you saw the different IVs or tube feedings or not tube feeds, If we're tube feeding, at that point in time, we're not seeing the nutritional markers change. No matter what we do, the nutritional markers stay low. But we're seeing a lot more symptoms related to this treatment. This is actively dying phase. It's a worsening of the last few weeks of life. Here you're really going to see some trouble with the swallowing issue, and we might have to change some of the medications that are still appropriate to give to a different route, whether that be sub-Q, rectally. They can't take them by mouth. They may also not need them. The systems have changed, and what was needed before may not actually work now. All these medicines that we've used for so long don't have the same effect. The reason is this body is such a miraculous, harmonious thing, and if one system goes out really badly, it affects all the others. It's a bit of a cascade. The noisy breathing, again, that's because the lungs are not able to clear fluids. This is when we really want to cut back on fluids, and the fear is that we're dehydrating someone. But if we test that, and we can use trials of some gentle fluids, and we see the breathing get worse, we know that the kidneys have failed. We don't need a blood test, and that we're watching the fluids build up back into the lungs at that point in time. And then you see the cooling of the arms and legs. We're also watching for a lot of the psychological and spiritual distress, and hopefully we have looked at the illness the person will likely die from, and we're preparing them along the way. Definitely not all at once, but along the way to look for these shifts so that they're getting the gold nugget information. So they're getting to make sure that they're seeing and attending to what is important to them. So I left you with some questions. My handout has some questions. And I hope that these will help with your family, with your friends, with yourself. What can I expect in the coming months of years? Think of the dementia patients. How will that progress over time? Think of the cancer patient. If the treatments fail, what will we expect to see in the years, months, days, as the disease progresses? How will we know when we're entering these final stages? Think about those shifts that we've just gone through, some of those symptoms that we are expecting, but be specific to this particular illness. This is going to be a really important question. What symptoms will I have, and is there anything that can be done, and is there an expert that can help us? Talk about your concerns, about the decrease in appetite, the inability to swallow, pain management, difficulty breathing. Be really proactive in saying, I don't know enough about this, I'm a little afraid of this part. And help them, ask them to explain why it might be beneficial, when it may not be. How are the different organ systems working? You really want to know if the gut's working. If the gut can assimilate or utilize, the cells can utilize nutrition. If it can, and we have ways of knowing that, then it's appropriate to try. If they're showing signs of poor nutrition, but they're not expected to die, it's worth a try. And if we start seeing these symptoms building up and we know that it's not working, it's okay to stop and allow for pleasure. My father died of dementia last year, and up until the last week of life, we ate a lot of ice cream. It was, as he was losing weight, I was gaining weight. But we ate a lot of ice cream because he was able to enjoy that. And it gave him liquid, it gave him a little sugar. But if the kidneys are not working, this is a big marker, and this will affect the ability to get fluids and respond to fluids. Resuscitation. Will attempts at resuscitation be beneficial? For the dying patient, imminently dying within days, you need a body that is actually still harmoniously working. When so many symptoms are no longer working, the success rate for successful resuscitation in the dying patient is 0. So resuscitation at that point, hopefully you've asked the right questions, you've attended to the things that are important, sacraments have been given, ask them to explain why. Ask if there's a palliative care service. And then ask the questions of the palliative care service. If they are not being answered in a way that matches your beliefs and values, continue seeking. All right? It's too bad that this is not, if you can see the patient is in the bed, his wife is by his side, he is at home. And Mass was being said at the bedside. This was 2 weeks before he died. 70% of people want to die at home. 70% of people do not die at home. We can do this. This particular person, this happens to be my dad, he transitioned early to palliative care. We treated infections as they came until it was clear that the infections were not getting better and the treatments were actually hastening his death by the side effects they were causing. And he died at home with his family around him, having just had Mass. So we can do this. We can meet treatments, we can match treatments to the patient and family goals, but we need a better understanding of what's happening to us so we can ask better questions and make decisions as we go.